to follow Dr. Kopecki. It'd be easier if I went first. So I'm so glad to be here again at this wonderful meeting that that Dr. Khan Mo has established. Incredible. And now Dr. Mufi, Omar Mufi. Got it. I'm very bad with names. It's tough. That's a challenge. So, well, my name gets fouled up too. I'm entitled to screw up a little because Amsterdam becomes Anderson, Armstrong, and so I'm in good company there. All right. So I'm going to do a perspective on current prevention outlines, the coronary epidemic, and I thought recent days, weeks, minutes before, some other information of note that has come. So let's look at that. My conflicts are only inner conflicts, but I don't care. As good an audience and friends as you are, I don't care to share them with you. I pay a lot of money to my therapist to share my inner conflicts. Okay? So, two big killers we have, and both organizations are fighting very hard to achieve success in reducing mortality. On the vertical axis, you're seeing total number of deaths. On the horizontal, year, and we see cancer is really on the rise. The blue line doesn't always come out in the same color, but this is. And the blue line, cancer continues to rise. We're very proud, since the middle half of the last century, to see a decline, a steady decline in mortality from heart disease. And that has finally brought women's deaths down from heart disease, down to men's deaths. Just a couple of years ago, women did not partake. The arrow doesn't work unless we wiggle the mouse. That's all computers. So women's heart disease has come down to equal men. Unfortunately, the last few years, there's a concerning increase in mortality from heart disease related to a lot of the things that Dr. Kopecki was providing ways of avoiding, mainly fitness, overweight, the metabolic syndrome, diabetes, and that is a major concern. So with that background giving us some idea, I do have to make one mention. What I call the women's lobby, that's not very politically correct, but I feel that a lot of the emphasis, I think I probably talked on women and heart disease here before, and a lot of the emphasis on heart disease in women, I think, has caused unnecessary alarm in women. We hear at every age, heart disease is the leading killer of women. Not true. Absolutely not true at every age. Postmenopausally and into older age, it starts to pick up with cancer. But how many of you are knowing a woman who died of a myocardial infarction, who didn't smoke, who wasn't a diabetic, and was premenopausal? Usually there are a few hands that go up. It does happen. How many of you know a woman who didn't smoke, reasonable lifestyle, and died of breast cancer or cervical cancer? Yeah. Why do we keep hearing this? And these are women under the age of 40, frequently. We all have friends under the age of 40, women who have died of breast cancer. It's not true that at every age, heart disease is the leading killer of women. It's always behind the mortality in men. It never catches up, although it gets closer and closer after the menopause with each year and each decade. Finally, after the age of 75, the CDC data tell us heart disease is now the leading killer in women. And because it's so great at that time, if you average it over the lifetime, it is the leading killer in women. I took the slide out because I had too many slides, but it's heart disease and cancer in women over the lifetime. They're very, very close. Heart disease leads by a little bit because of the huge amount of deaths in women from heart disease late in life. That means we still have to practice what Dr. Kopecky was just telling us and prevent heart disease and treat the variables that cause cancer. I have to get that in there because I think that's very important. I had a little debate with a leading researcher in heart disease in women, a very good contributor to this problem, but we don't want to alarm women unnecessarily when the deaths from heart disease under the age of 50 are quite small compared to cancer. Protection, protective, preventive cardiology, absolutely, but not alarm over, I'm going to die of a heart attack. Women are dropping dead. Okay, we're going to cover some of these areas. This slide shows deaths on the vertical axis per 100,000 over a period of about 70 years. And here you see what's not shown is heart disease rose in the beginning of the 20th century, continually rose until we got to around 1960, 70, and it leveled off, and it's been dropping since then, except for recently, not shown here, a bit of a rise, and we just talked about that. So we'll cover some cornerstones of preventive cardiology during the last century. In 1961, it was only a little over 50 years ago that the risk factors were defined, documented, and recognized, the work of the Framingham study and other leaders in that area. In 1974, the LDL receptor was isolated by the Nobel Prize winners Brown and Goldstein at University of Texas, Dallas. Interestingly, very soon after that, the HMG-CoA reductase inhibitor, the first one, was described. And what was that drug? What was the class of drug? Statins, called HMG-CoA reductase inhibitors because that's where they interfere with the metabolism and production of LDL cholesterol by the liver. LDL cholesterol, the necessary risk factor, the primary risk factor in atherogenesis. Other risk factors are very important and do their harm, such as cigarette smoking, even in the absence of a high LDL cholesterol. But we don't have atherosclerosis unless there's a minimum concentration of exposure of the endothelium to oxidized LDL cholesterol for over a period of many years. That could be debated, and I'd like to know Dr. Kopecky's idea on that. But that is, to many, the necessary risk factor. Next, down here, NCEP, the National Cholesterol Education Program, was developed. ATP1, the National Cholesterol Education Program, from the NIH. And there have been about 4 iterations since then. We'll talk about those. Major contributions to our understanding of prevention. And finally, into the current era of gene analysis, looking forward to personalized medicine in this century, maybe a lot earlier in this century than one might think, of personalized medicine based on the genome, the personal gene. And then the PCSK9 inhibitors, which have been very exciting. Haven't found the spot where they're going to level off at, but very exciting and very important for a small group, but a very important group of individuals who don't respond to statins, not that small, and those with gene defects that cause familial hypercholesterolemia. So here's a case of a 54-year-old male colleague, active asymptomatic, waiting for an airplane in Los Angeles a few years ago. Post-mortem, or at the cath lab, there was an LAD plaque noted, but he had a rupture of that plaque and a large anterior MI, and he had been quite active and asymptomatic and didn't have a bad family history. So what was the problem there? How can people have sudden death and not have any symptoms beforehand? The spouse, usually a woman, usually a female, of the male victim, could be the reverse also. So how can this happen? It's hard for laity and some of our own colleagues to understand. How can this happen in an active person who never had a symptom before this? So let's look at this. Actually, CAD is the major cause of cardiovascular disease mortality, the leading killer in our society. It presents as sudden death in the absence of prior symptoms in about a third of deaths from coronary disease. It presents as sudden death, myocardial infarction, frequently in the absence of prior angina or symptoms, and angina to those who are going to manifest their coronary disease, angina, stable angina pectoris, stable ischemic heart disease is the initial manifestation. That's a lucky third because they don't have the first two disasters. So what we know is that coronary artery disease, the initial manifestation is a calamity, either sudden death or a myocardial infarction. Initial manifestations of coronary disease. And what is that? That's the case for primary prevention. So here is an artery, a coronary artery, cartoon. Could be a cerebral artery, could be anywhere in the body. Notice first decade, third decade, fourth decade. Notice the plaque is starting in the first decade. It enlarges, big lipid pool, finally there's rupture, occlusion. That same process can happen at a sub-occlusive stenosis. So under 70%, under 50%, we can run around. We still have adequate coronary flow reserve so that there's no angina. We have adequate coronary flow reserve. And this is plumbing, and it holds true for the renal arteries and other arteries of other organs. But those plaques that are not causing a problem, if there's a big lipid pool and a thin fibrous covering, a severe or a modest plaque can rupture and cause infarction and sudden death. The case for primary prevention and even primordial prevention. What's primordial prevention? That is the prevention of the risk factors, and that goes to youth, to being raised on a diet, on a physical activity, on a lifestyle, being fed in a way that prevents or averts the risk factors. That's primordial prevention. Primary prevention is once we see the risk factors, treating those risk factors to prevent the event. And secondary prevention is getting in after the horse is out of the barn and treating so that we don't get another event. And much of the success of risk factor reduction and preventive cardiology has been in secondary prevention, less so in primary prevention. Obviously, when there's something to treat, we treat it. We don't recognize the risk factors as well. This is just to remind us that atherosclerosis is not only coronary. The brain also suffers from this. And it just kind of gets a little bit related to what Dr. Kopecky was saying. Who would rather have a stroke than an infarct? I don't know anyone. We would rather, if we have to have atherosclerotic event, the infarct is actually preferable to the stroke, a big stroke, and then surviving with a big stroke. We don't want to have either, but we need to think we're also preventing atherosclerosis in other organs of the body. Just to emphasize that, I don't know, yes, this is projecting well. This is a normal brain, and here's one with atherosclerosis. All the little white spots are small strokes. The little and medium-sized white spots here. So we don't want to have this. We're always shown arteries of the coronary arteries. We also need to think of other organs, particularly the brain. So we're going to go through in the next, I know Dr. Mufti is a good organizer. He's looking at his watch. I think I'm doing okay. but probably I have a reputation for going overtime, so that's fine. We're going to talk about primary prevention, residual risk, how early does atherosclerosis start, how early to treat, and then the diet, low fat, Mediterranean, Esselstyn, risk factor reduction, and then some metabolic and genetic aspects. So primary prevention. Again, LDL cholesterol is the main, if not the primary and necessary, the main driver of atherosclerosis. I say it's the necessary, the atherogenic factor. The major dietary source of LDL cholesterol in the blood is saturated fat. Saturated fat. Every decade there is publicity and TV interviews of the publicizer, the fact that we're misleading the public. This idea that cholesterol is the problem is a conspiracy between industry and academia for money to sell pills and for academicians to get grants. It happens in every decade. You can turn on your computer and see how horrible and dangerous the statins are. And it's a conspiracy of doctors to see people and treat patients. The most recent is that a high-fat diet is not only not harmful, it's very good. And that's happening right now. So we have to be aware. There's a person who we look at, if you read echocardiograms, the computer always is estimating the volume of the left ventricle. And there's a name by which it always lists the method. And blocking on his name. It's a long name. I'll stop thinking about it. Anyway, it's the same name. I don't know if she's related to him, but a year or two ago, she wrote a book on it's not about fat at all. Atherosclerosis is not about fat consumption. And same name as this guy who developed a method, a useful method for estimating volumes on echocardiogram. Embarrassing that I can't remember the guy's name. But you saw her if you watched television. She was going around with interviews on her. But it's always good to say that fat is bad, saturated fat. One candy bar contains 12 grams, 10 to 12 grams of saturated fat. That drives the LDL cholesterol. And to say that, that's not harmful. A good diet, we want to be under 20 grams of saturated fat a day. A really good diet, a rigorous diet, is under 10 grams of saturated fat a day. A great diet, in my opinion, is the plant-based diet, a vegetarian diet, free of horrible simple sugars, fructose, all of those that promote metabolic syndrome, diabetes, and inflammation. But saturated fat is the key. And we see this in every decade. There is incredible amount of evidence on connection between saturated fat, LDL cholesterol, and atherosclerosis. So you've all seen this before. The risk factors are continuous and graded. And on the horizontal is serum cholesterol. The LDL cholesterol is about a 50%, 40 to 50% when you see total cholesterol. Over here is mortality. So we know that mortality goes up. This is the Mr. Fit study done back in the 90s, the early 90s published. But what has happened with our therapy? Before we talk about that, let's look at a little bit of history. Here we have on top hunter-gatherers, a little bit of anthropology, and Dr. Kopecky alluded to that. The evolution of our technology has outstripped our ability of us as an organism to evolve also. So I won't repeat too much what Dr. Kopecky said, but we're adapted to not having available all the foods we have, and so the foods we ate to keep alive and the fitness we had to keep alive were all part of another decade, things we did. Now technology has taken away the drive, the need to be fit and to eat the foods that are barely available. So So our technology, our advances have outstripped our ability to adapt. And stress also, we are under constant stress, which we were at the time the saber-toothed tiger was chasing us. And no saber-toothed tiger now, but it's many other issues that we deal with that keep us at a low grade of stress, high adrenal cortical hormones, high adrenal medullary hormones, the catecholamines, at a constant grade, which are deleterious to the function of arterial vessels. On the horizontal axis, you're looking at total cholesterol, again, 40 to 50% LDL, then wild primates and wild mammals. So you see that the total is well under 200, under 150. So the LDL is going to be somewhere in the 70s to 50s or even lower, depending on the animal. This animal has an average cholesterol of around 200. And if you can't read that, that's humans. And an LDL, if it's half, is above 100, 120, which is, remember, average is not normal. People used to say, I know speakers that would say, in Oakland, every Saturday night, the average is 5 to 7 murders. That's average. So it's normal. Normal is not always appropriate. And that's why we look, okay, stirred things up a little with that analogy. I know maybe not politically correct. It's a city, it's people, and so now our LDL cholesterol is fairly high, and as I said, again, 50%. And why can't we be like the hunter-gatherer who has an LDL that's going to be down well under 60, 70? Why can't we be like that? Why don't the guidelines stress an LDL under, not just for people who have had a myocardial infarction? Should we be like hunter-gatherers of old? That would be nice. I think that kind of blends with what Dr. Kopecky was saying. We'd not rather live in the cave, but we'd rather have some of the attributes that occurred then. How about with respect to LDL cholesterol? Just being provocative here. The guidelines come down slowly. They're evidence-based so that they don't get too far ahead of where knowledge is and information and cause problems, cause adversity. So they have to be like that. Just being provocative, where we are going. The LDL cholesterol recommendations have, in the first guideline, NCEP, that I showed you in 1976, I think it was, or 74, there was no primary prevention, there was no secondary prevention, and there was no LDL cholesterol. And as they've gone to NCPE 2 and 3 and modified 3, we're now in the early 21st century. Then for secondary prevention, it's been at least LDL under 100 or optional under 70, and we've all adopted under 70. But we're not there in primary prevention. In fact, primary prevention is okay if you have no risk factors, no risk factors in quotes, no risk factors, as long as we're under 160, and previously under 190 to begin treatment, or over 190 to begin treatment. So let's look at a review that was written by Dr. Vogel, Robert Vogel, and his colleagues a couple of years ago. He's at University of Colorado. What we're going to see is a couple of graphs like this. Mean luminal decrease. So this is the decrease in millimeters in the lumen diameter of, usually it's the carotid artery, can be the coronary. And these are different studies. So they're all looking, P is placebo, and then you look for the MOS down here, what happened after the LDL cholesterol was lowered. The studies are fairly short, 2 or 3 years. They're quantitative coronary angiography, not eyeball, but still some reject this because look at the changes. Mean decrease in millimeters of mercury per year. Millimeters of mercury, 0.04 millimeters. Pretty tough. I don't know if there are any radiologists here. When we do our conference in Hawaii, there are always ringers like radiologists from Australia. What's he doing in a, you know, it's nice to go to Hawaii. You have a deduction. Who cares whether you learn anything or not? I'm afraid some of our attendees, we always have attendees from Scandinavia. Some are cardiologists, but we also get outliers. Retired pathologists. How's that? So I don't know if he takes back a lot of information. We love to have them. But the point of this is, look at, we almost have a straight line. A straight line. Notice how they're all going down. The if you can always find here is the placebo, and then L-CAS is down here. That means here was the control at 140. Then statins were used to reduce the cholesterol in the blood, and now at 110, he dropped from, what's about 0.035, he dropped to about 0.01. There is a consistent, you can go through all of these the way I just did, a consistent reduction. Is that good? Well, we know now from studies in the early 90s, that doesn't make a lot of difference in flow or coronary flow reserve, but it makes a lot of difference in function. So these tiny changes in the coronary arteries resulted in tremendous changes, reductions in myocardial infarction, in death, in occurrence of angina, in peripheral arterial disease onset, in strokes. Small changes, because what did it do? Now we understand. It stabilized the plaques that rupture and cause the coronary events. So that was that. Let's look now at, it's very sensitive up here. Okay, now we're looking at LDL cholesterol in the horizontal and coronary heart disease events in primary prevention. That means the patients had risk, they were high risk to get into a study. The best thing about all these trials on statins and what I'm showing you here was that you didn't qualify for one of these trials because you had to have either events or high risk. So not qualifying was very good. Okay, so here were a few studies in primary prevention, and interestingly again, a straight line. As the LDL cholesterol came down, this is an easy one, Ascot placebo, Ascot the statin, and coronary events percent. So these are absolute. So it goes from about 3 down to about 1.5. Very important in terms of what it does to function. And look at the events. Okay? Now, where most of the data are is, again, events. Now, look at this, just interestingly. When you do a primary prevention trial, look at the vertical axis. Look at the ordinate. It goes from 1 to 10. Now, when we go to people in secondary prevention, they've already had an MI. Look at the axis. For primary prevention, it only went up to 10%, and it took the whole vertical axis. Here we go up to 30%. Why? Because there are so many more events in secondary prevention, and it's easier and shorter time to show a beneficial effect on events. And you've seen this over and over. Here's the famous 4S trial. Patients were up at 190, LDL cholesterol of 190. That's the top 5%, or maybe 1 to 2%. And where did they go, the 4S? Down here to under 130, the 4S statin trial, and they had a 30% reduction in events, a relative reduction of 30%. And the same thing. Now, the key is to look at where that intersect with 0 is. We don't have any data down here. And it's a little dangerous to say, boy, and in primary prevention, look at where the intersection is. of coronary events. The intersection with 0 as you get to an LDL of 55. That's in primary prevention. In secondary, we have to go down to, we have to go down below 50 in secondary prevention. That's a dangerous thing because we don't know where the inflection point is. It may level off right there. It may level off right here. We don't know that it's going to go down there. But there's some other data that's very provocative in how we might be treating our patients. And there's a word on the guideline. They're clear on secondary prevention. If the person has events, has known disease, or has an LDL of over 190, just blast them with a high-intensity statin, rosuvastatin or lovastatin, or Lipitor, high intensity. It's pretty clear, and the residents like it. It's not so clear if they've not had an event. It's kind of fuzzy on primary prevention. You have to look at who they are. I mean, you should do this, but the visit is 15 minutes. And then you have to calculate their 10-year risk, and if it's over 7.5%, then you go to a moderate intensity statin. Now that sounds pretty easy, and how many of you are looking at use, and don't be embarrassed. There's no reason to be embarrassed. Use the old, not so old, 2003. That is, you look at the framing. I'm sorry. You use the target LDL. If the LDL is high, then you want to get it to a certain level in primary prevention, under 130, optional under 100. If they've had secondary prevention, under 100, optional under 70. So that's the 2003 ATP. And now we have don't do targets, but you do have to get it to make sure they're absorbing the drug. How many of you use the 2014 no targets? And how many use the prior guideline, the old one? And how many of you use a mixture of the two? I do that. I want to follow the targets. I do not eschew the targets. You're doing targets anyway. A few weeks afterward, you want to make sure that the LDL is going down. Either the statin's not working, if it doesn't, or the patient's not absorbing it or not taking it. So, but the point is they don't want you to follow. One is not supposed to follow. And I showed you all of this data beforehand on the straight line, which goes way down and maybe even lower than it looks. I'm looking at my watch. And so do not be embarrassed about admitting or using the prior or the current. The key is not to have a war over which one to use. Do something, and both are rational. And many are unhappy. Many experts were unhappy with the absence of targets. That caused a furor. It almost was like Obamacare is right now. Should we replace and renew, or should we leave it alone, or what? And there were reds and blues. So I just dealt with the no target LDL. That's up for grabs, as long as we're doing something for our patient. Now, Brown and Goldstein we refer to. They won the Nobel Prize, and they wrote an article in the journal Science, a highly prestigious journal. In 1996, they wrote this editorial. They discovered the LDL receptors, and then came the statins. Heart attacks, gone with the century. That's a statement. I added the question mark. Gone with the century? Down, but gone with the century? These guys obviously were not clinicians. They made a tremendous contribution, but that was a little hubris, personal hubris. Good guys. And they did say very appropriately, if we wait for susceptible individuals to develop symptoms, before deciding to treat, the earliest symptom is often sudden death. They were pretty damn good clinicians on that one, or a myocardial infarction. And we have a strong lobby. Some of it's coming from a well-known individual who edits a journal, a very good journal, in the Bay Area, very good medical school, about don't treat patients who are asymptomatic. The only thing that'll result from that is more money for the drug industry, and I don't know if he/she says, I've given away enough already, says that it's going to pay more people on statins, more side effects from statins, and more money for the drug companies. I am not a fan of the drug companies, but there is no conspiracy. All right. So I want to go into another area. No politics here. I'm really restraining myself. But,
Thank you.
I was told no politics. I did a couple of years ago. I did the Vietnam War. All right. Your patient's 10-year risk. Your patient, we're now in the office, is you calculated it. You're using one of the two risk calculators, and it comes out to 14% risk over 10 years for fatal or non-fatal heart attack or stroke. Your patient says to to his/she, his/her, political correct is driving me crazy, says, "Dear doctor, your dear doctor, what does that mean? I need somebody to tell me what that means." Every place I ask that, I get some answers, but it's very rare that I get the correct one. It's too bad we don't have an audience response. But does anyone want to say what that means? No takers. Well, I'll tell you the answers that come out usually. Well, it means that the patient is going to have one of these things in 10 years, has a 14% chance for it. We call that circular. It's not an answer. What does it really mean? This may, if you don't take away anything else from my remarks, this would be worthwhile, I think. And I think spending a half an hour or an hour at any session and learning something one didn't know, I apply this to myself, it's well worth the 30 or 60 minutes. One thing. So you explain. Of 100 people with your risk profile, Mr./Ms. Jones, 14 are at increased risk for a CVD event, coronary or CVA, fatal or non-fatal. And we have a very skillful way of transmitting that. We don't just blast the patient. 14% stroke, MI, fatal, non-fatal. We do it in a reasonable way. In the next 10 years, 14 people with that profile are at high risk or will have. But at this stage of our knowledge and know-how, we don't know which are the lucky 14. So we treat everyone with this risk profile to avert events. We're on the cusp of going into personal medicine and being able to say, this person is the one. This person is one of the 14. We're not there yet, so we treat everyone. And so I'm going to go down in my list. I'm sorry, it isn't the last thing I'm going to talk about, though. But I'll stop when you want me to stop. I did start a little bit late. All right. So in The Lancet a few years ago, there was an incredible article, I think, in telling us we really are close, by Ashley at Stanford. They did the genome. This was 2010 in The Lancet, 2010. They looked at a single person's genome. And what their findings were, they said, we found 3 genes that are clinically associated with sudden cardiac death. Associated. Now, heredity is not fatality necessarily. It is not events. because we have to stop the 50% of the risk is heredity anyway. It is not. Notice how they said variants that are clinically associated. It's not necessarily cause and effect. We can offset that heredity in many cases by the way we know to reduce our risk. The things we can reverse, we can do to reverse risk. We should do intensively. Do the things that Dr. Kopecky was talking about. But these are 3 genes. Also, probable gene mutation, a CYP, a mutation suggesting probable clopidogrel resistance. You see? Possible. And a positive response to lipid-lowering therapy. All of these related to genes. Now, somebody who has a gene for freckles will not get freckles if he or she doesn't go outside in the sun and stimulate the hormones that are related to freckles. So this doesn't mean this is going to happen. There is an interaction, and that's all been shown with twin studies a long time ago. Here, the cost per human genome and how long it takes. So here we're looking on the vertical axis at money in millions. Horizontal axis is time from 1990 to 2012. Here, at this point, it took in 80, it was 13 years and 3 billion. You know how they say on the radio, with a B, not million, billion per genome. One of these small areas, one of the little areas in the genome per dollar, and there are millions. As this technology has improved, was now down in the early part of this century to less than 2 weeks and around $1,000, and now it is days and less than $1,000 in 2014, and that is really moving very rapidly. We're already 3 years beyond that. So that is how we can say that's probably a person of one of the 14. This is probably not one of the 14. That doesn't mean you have a clear bill of health, because we don't know all the genes and won't know them for almost forever because of the number of genes. So the loss of function of the PCSK9 inhibitor is what is making alirocumab and evolocumab, the PCSK9 inhibitors. They have a loss of their function, and what this PCSK9 does is it is involved in the degrading of the LDL receptor. The LDL receptor goes through a cycle. It goes back into the liver, goes to the cleaners, gets washed up, gets retooled, then comes back out on the surface of the liver. And then the PCSK9, after a while, takes it and runs it through again. So everything is in motion. It's a process. But if we inhibit, not we, but if the gene that controls the PCSK9 inhibitor loses its function, we have lots of LDL receptors on the liver. And there's a wonderful slide that shows that, a cartoon, which was a couple of years ago, but I didn't put it in for time constraints because it's very detailed, but it's wonderful. You should give it to all your patients. Show them what's happening and where this works. So it is a naturally occurring mutation of great benefit, and I just talked about its degradation. More LDL receptors, less LDL cholesterol in the blood, less atherosclerosis, less events. Remember, LDL, the necessary, in quotes, atherogenic risk factor. So some mutations are great, and when they really are beneficial, we call them polymorphisms. Here's another interesting mutation, ANGPTL3. That's a protein that circulates around. I don't know what it does, but its absence is associated with much lower LDL and plaque burden. Here's the cousin of that guy who didn't have that mutation. Wild type doesn't mean he's a wild person. It means nothing's been done, and this is what he has. Nothing's been done to change it. We use it in laboratories more. But look at the plaque burden here. Let's say it's the carotid artery. So there are these are not only interesting now, but they are going to be the target of gene therapy in the future. So the natural experiments of nature in humans will provide a basis for going forward, just like the natural loss of function of the PCSK9 provided the basis for going on and making a drug that interferes with PCS, interferes with the degradation of the PCSK9. Here's another one. They're popping out all over the place. This is recent also. The mean change from baseline in the level of PCSK9. We don't have to go over all these lines. This is placebo and where PCSK9 is in terms of change. It's not the level, it's the change. No change in placebo. Here are different doses of this agent in glycerin. Oh, I had it on here. In glycerin, it's called. It's an RNA agent. RNA, they control the formation of proteins. And here is RNA acting to inhibit the production of PCSK9, and look at the change in PCSK9 in the blood. That means less degradation, well, refer to it as degradation, of LDL receptors. More receptors by a totally different mechanism than the PCSK9 inhibitor drugs that we already have. There's three things that are beneficial. We have plenty of harm. Now, I think the last thing I'll talk about, I don't want to, how long does the panel go? Panel's on at what?
Panel will go for 30 minutes, so we are left about 20 minutes.
Okay, so I'll just do one other thing, residual risk, because the panels are better than the lectures. Personally, I think, at least my lecture. Okay, so we'll do residual risk. There's benefit with our drug therapy. What is residual risk? The risk remaining after a successful intervention. It could be the police on auto accidents or reduction of alcohol. Here, example is statins. After the statins have reduced the risk, for example, in CAD, there's still risk left. We have to realize that. I mentioned the 4S survival study. Here it showed 30% reduction. On vertical is patients alive, so a higher curve is better. These are the survivors, and this is placebo. This goes back a while. 30% relative risk reduction. But a really perfect approach would have been a curve that was higher than even the statins. More people alive. People are dying. And usually the residual risk is higher than more people are dying than are saved by the statin, which is better than no statin. So here's a better example of that. Substantial risk, residual risk, cardiovascular and statin-treated patients. So this is a big study, the heart protection study, which shows percent of patients on the vertical axis and year of follow-up. So this is the other way around. Percent of patients and that have an event. And here is the statin. Fewer patients have an event. And here is the placebo. They're getting everything other than a statin at that time. There's about a 20% of statin-treated patients had a major cardiovascular event by 5 years. But they're less than the placebo. But this is all residual risk. It's what's the intrinsic risk in the population. It could be cancer, could be an auto accident. Some of them you can't do anything about, but others are more cardiovascular events that need to be looked at. So here's evolocumab, one of the one of the PCSK9 inhibitors. Here's the LDL cholesterol on statin. Add evolocumab and look where it went. The average is down in the 30 to 40, and this is 3 years, a little over 3 years. Here's the placebo. These patients are getting everything they should get except evolocumab. And look at the difference here in LDL cholesterol. This is, I'm not having time to go into it, this is what we're born with. 40 milligram percent, or 40 milligrams per deciliter of LDL cholesterol in the infant, who needs a lot of substrate to make cell membranes, to make hormones, and does very well, very rapidly growing. We don't, again, it goes back to what Dr. Kopecky is saying. Our lifestyle was outstripped by our technology, and we have these LDLs that are up over 100, and we start with 40. And then what happens? The events. So here are the events. This was a New England Journal not long ago, and this is cumulative incidence of these events, mortality, et cetera, and this is pretty short, 3 years, typical curve for a cardiac study. The separation between the therapy and the placebo starts quite early, and it continues and continues to split as the study goes along. And here they did it a little differently, same death, MI, CVA. So residual risk is under here. Now remember, this is not 100%. This is a blow-up of the whole thing. So there's still a fair residual risk. Lipid reduction. Now, there's not only residual risk, but there's variability and anti-drug antibody formation with this drug. Bococizumab, anti-drug antibodies were developed, and there were a large number of studies, about 6 studies. It attenuated the LDL lowering effect, and the drug was dumped and is not studied anymore. So it doesn't always work. But the Fourier trial that I just showed you with evolocumab, we worry about adverse effects. Here are the important ones, and there's no difference. More were studied, and there was no significant difference. And this was a big one, worrying. You still see stuff about the statins and the PCSK9 inhibitors. They're causing neurocognitive deterioration. A very strong statement by Di Guglielmo from the Brigham. Evolocumab, this was evolocumab. It doesn't make patients dumb. And you just saw that. So we have to follow them longer to make sure. And with that, I will stop. Maybe next year we can do the others.
Thank you very much. We'll ask Dr. Kopecky to come up and try to give you some practical points. You know, when you call Dr. Amsterdam to ask him if we would speak and when we discuss topics, and I'm running in between patients, I have just a few minutes. Boy, if we talk about a topic, he's going to give me a lecture on the phone right there and then on the entire topic. So thank you for coming. So let me ask you, both of you. You know, yes, in newborns, we need, they have an LDL of 40 milligrams per deciliter, but with these PCSK9s, we've seen LDL levels down to 15 and even lower. How low is too low?
That's a very good question, and Brownstein and Goldstein actually researched that. They were researching LDL for 17 years before they got the Nobel Prize, and they found Goldstein has said recently and published that 25. You need an LDL of about 25 for your for hormones, sex hormones, things like that. At Mayo, we go down to 30, and then we say less than 30. So we give numbers down to 30. So we just try to keep it over 30.
Yeah, these trials, some of the statin trials, TNT had people go. That was a statin. They used a statin, and the LDLs went down into the 40s and some 30s. No adverse effects, and with the PCSK9 inhibitors, the same thing's happening. And it's interesting that in, I will try not to give a lecture on the phone, but I didn't get to this, but it's very fascinating. I keep saying that LDL of 40 is all we need. That's what we're born with, roughly. In mother's cord blood, the LDL in one study was over 100. Mother's blood, LDL was over 100. In the cord blood, what the baby had was an LDL of around 40, 30 to 40. So it's very rational all the way through, like Steve just said, and we see this, the 40, and then it goes up over the years in relation to the amount of saturated fat in the diet.
So one other question from my standpoint, and then I'll open it up. Now, we don't quite understand why patients develop myalgias and myositis with statins. But one of the thinking is that when the LDL levels go too low, they develop these muscle aches. If that's the case, then why don't we develop it with the PCSK9 inhibitors?
They don't develop it, and that's the key thing. We know there's an interference with the production of some of the related substances in the muscle. The statins do this as they reduce the production of cholesterol, and that's why you have an ad or some people giving
coenzyme Q?
Yeah, giving coenzyme Q, because coenzyme Q is one of the substances that is reduced, and I know of no data that supports that. It doesn't hurt anybody, but there are many ways to try to avert the problems that occur with myalgias. The myositis, the true myositis, is less than 1 in a million. So we don't have to worry about that, but it's always less in the blinded trials than it is in the clinic, and there are a couple of reasons for that. To get into a trial, you have to be the healthy among the sick, so perhaps we're not looking at the right patients. The trials deceive us because we see different clinic patients anyway. So I think there are so many ways to get around that, and then there are other drugs one can add, lower the dose of the statin. There are a million ways you can go.
It is interesting. I have some patients on PCSK9, and they have muscle aches. And if you look at people who get liver transplants, they drop their cholesterol quickly because their liver can metabolize it. They get muscle aches. So the interesting that Ezra was talking about is in the PCSK9 trials, they actually, one of the trials you had to go, it was a statin intolerant trial. So you had to be statin intolerant to get into the trial. But the first month, we gave patients placebo statin, placebo PCSK9. We couldn't tell them. Every patient I had called me and said, I am on the statin. I ache like crazy. And I said, well, if you are on the statin, if you're aching, if this is exactly the same as you had before, then you can't go in the long-term trial where you get free drug for a couple of years before it was approved. And they said, if exactly the same? I said, yeah, exactly the same. And they said, it's not exactly the same. And the problem is that when you give someone a statin and you tell them it's a statin, they have muscle aches. These trials did this. They actually gave people statins and didn't tell them, or gave them placebo, didn't tell them. 50% of the people that got a statin got the same symptoms. 25% of people that got placebo got the exact same symptoms. And so 75% of people can take some statin. It just may not be a daily full dose. You know.
Questions? Dr. Palmer.
Just a comment on the little child. I enjoy your talk, and I agree with everything you said. But a little story. About 150 years ago, and no more than 2 hours drive from here in Lucas County, there lived the Maidu Indians. Their diet was almost completely vegetarian. They ate acorns, wild apples, and berries, and they walked about 30
tell him so everybody could hear that.
The good question. I don't know if you heard that, but the Indians used to live here, and they eat acorns and apples, and they walk 30 miles a day, and they only live to be 40. And that's like one caveman says to another, we're eating perfectly, we're being active physically, but we don't live past 40 years old. What's the deal? And of course, they died of communicable diseases, primarily, not non-communicable diseases like we develop now. That's very interesting. I mean, you bring up an interesting point. And what's the ideal? What's the longest lifespan we can have? I don't know, but people say it's well over 100 years.
I agree with that. That's an interesting point. My point is, as Steve said, there are other things they're dying of until as heart disease went down. Before heart disease went down, it was the leading cause of mortality. Then it became infections. And what is the leading cause of mortality in the world? Malaria. Because it occurs in countries, huge populations, and the disease is not controlled, at least unless it's changed very recently, it's infections. So, and they had other things. They may have eaten acorns, but that's not a balanced diet either. And they had some wars going on, and they had a bunch of other issues. If they didn't do what they did in terms of the vegetarian diet, and I would say, and the exercise, they wouldn't have lived to 45. So in spite of that.
All right. So we have some questions that some people wrote down on note cards. That one of them is HDL protective in the setting of an elevated LDL? And how would you modify the LDL guidelines in the presence of high HDL levels? To both of you.
The Framingham used to take points off your risk if you had a high HDL. They no longer do that because genetic studies have shown if you're born with a high HDL, it doesn't necessarily protect you. I've told women in my career, your HDL is 120, you're not going to have a heart attack. They've gone out of their way to find me later, 20 years later, by carrier pigeon or email, and say, remember you told me I wasn't going to have a heart attack? Well, I had a heart attack. And so the reason is that HDL does at least 5 things. One of the things is reverse cholesterol transport. It also fights, and it has to do with anti-cancer. It's endothelial function. It's platelet maintenance and endothelial maintenance. So if your HDL is high, it doesn't necessarily mean it's the reverse cholesterol transport HDL.
Oh, and I would answer that question by saying the treatment for a low HDL is a low, very low LDL. And don't worry about it. Don't have a person drink alcohol. Don't tell them, like one very, very good person, he was a hypertension expert, not anymore, but he retired. But he would say, oh, it's a low HDL. I tell him to get a bicycle and bicycle to the liquor store. To exercise, yeah. I never tell a person who is not drinking to start drinking alcohol. 1 drink a day, men 2 drinks, women 1 drink. You don't know where that's going to lead to, particularly if it's a relatively young person. A major cause of mortality is auto accidents and drunk driving. Red wine, white wine, it's alcohol that is associated in the epidemiologic studies with a putative reduction. It's not been proven.
Okay. And then the suggestion that statins raise your A1C levels, and then do the anti-inflammatory second to that, do the anti-inflammatory properties of a statin trump the elevated levels in the A1C?
The people that do get diabetes with statins are the people at risk for diabetes. Meaning if you have elevated fasting blood sugar, elevated A1C, metabolic syndrome, they're the ones that get it. The people, and they get it if you go on a statin about 3 months before the people that didn't go on the statin. So it means you're going to get it, but you just get a little earlier.
And then can any one of you speak to or comment on the risks of smoking cigarettes versus marijuana to vascular disease?
Okay. Smoking is the single worst risk factor for everything, mortality and morbidity in our society, from diseases from the tip of your head to the tip of your toes. Cigarette smoking causes those. Marijuana is still being evaluated. It was felt to be benign. It was felt to be there are some data that the intake of hydrocarbons that you might take are harmful, very controversial, very laden with political background. So I think we can make there's no comparison here. You're talking about the worst risk factor we have and one that is now in evaluation, very controversial. Can't compare them. Nothing compares with cigarette smoking, not even LDL cholesterol.
All right, and then
Let me come up with. Well, if you look at Interheart and you look at some of the other studies, I mean, LDL, cholesterol is the number one risk factor.
You mean over smoking?
Over smoking.
Okay, so then you have to look at the dose of smoking, because we just say smoking or not smoking. Are they active smokers or have they quit? And so the way the studies are done in terms of assessing the smoking is these are huge epidemiologic studies. So to make them simple, it's usually a yes or no. Sometimes it's active or past smoker and non-smoker. There may be 3 categories. The LDL is measured, so I think it's hard there. I'm all for championing the LDL, absolutely. And that for cigarettes, now we're talking in those studies you're talking about for heart disease. What about all the other things that cigarette smoking causes? I said from the tip of your head to the tip of your toe. That was a good point. That was a good point, Mo. That was great.
This one's directed particularly to Dr. Kopecky. Can you please comment on the benefits of a vegan lifestyle and what would be the best psyllium supplement out there?
Well, the vegan lifestyle, if you're eating, macaroni and cheese all day long, I mean, that's a vegan, but it's not a healthy vegan. So it really needs to be, I think, fruits and vegetables is the 5 servings of fruits and vegetables is the important thing. The best psyllium, the thing with psyllium, everybody makes it. Every Shopko or Walmart or Kmart has it, the generic brand. You just got to be careful to get the sugar free, because the sugar takes a lot of space in the psyllium, and you have to take 3 times as much psyllium if you have sugar in it. You get more calories and you get all the space. So just get the sugar-free stuff, and try to get the dose is supposedly a tablespoon a day, a minimum, but it's a dose-response curve. If you want to take like 2 tablespoons 3 times a day, that's also will lower your cardiovascular risk and your LDL more than a lower dose.
I would recommend reading Esselstyn's work. Esselstyne. Esselstyn. He's at the Cleveland Clinic. I'm sorry, Cleveland. They have a great friendly rivalry, Cleveland and Mayo, but he's a guy who was the chair. He was chair, I think, of breast surgery at Mayo at Cleveland Clinic, and at least he was a breast surgeon. Got a little older, got into this. Has a book, Esselstyn. I'm not here to advertise the book. I only met him one time, but he advocates the plant-based diet. He's got angiograms. Unfortunately, no controlled trials. And I've got the slides. I didn't have time to show them. They're spectacular. Tremendous disease, and then 3 years later, a repeat angiogram, and it's not one case. It's lots of cases, and the lesions are gone, peripherally, coronary, and if you ask, why don't you do a controlled trial, he says, well, that's not ethical, because people should be eating a plant-based diet. But he's already got, everybody's a control, because very few people are eating the plant-based diet. So he could take any general public people, you have to do an angiogram. He could do a CTA angiography. But he's got a very nice book and advocates the plant-based diet, which I think is the diet we should all be eating. It doesn't mean you have to be religious about it. I am a lazy vegetarian, so once in a while, but never meat. It could be something else I shouldn't be eating.
It seems as though you got a look at this next card here. What's the difference in outcome in regards to lowering your HDL in the Esselstyn diet versus statin meds, so we've addressed that. So another question: what causes plaque rupture, and do we know? And this is particularly for Dr. Amsterdam. Are there any studies being done to find out if it's more common, certain chemical or structural situations?
It's a plaque rupture is a huge subject, and it has been for at least over a decade, several decades, and that is the vulnerable plaque. What is the vulnerable plaque? What we know, it's observational, is the plaques that tend to rupture are the ones with a large lipid pool, a thin fibrous cap, and contrary to what was said a decade or two ago, they're the ones that are associated with non-obstruction, the non-obstructing plaques, that the ones with 80 and 90% lesions, they don't rupture. That is not correct. The other factor, large lipid pool, thin fibrous plaque, and very occlusive, based on studies now more recent. The reason that it looked like these were the non-occlusive plaques is because if you have a severe plaque, then statistically the whole coronary system, whether you see it on an angiogram or not, is plaque laden. So if you have 1 million non-occlusive plaques and a very few occlusive tight plaques, then you're going to have more infarcts, more rupturing of those non-occlusive plaques, because it's just a statistical issue. So that's one, and now very good imaging studies are being done to look at the contents of the plaque, what makes it more likely to rupture. We do know that they're surrounded, the ones that rupture, there's high inflammation, and those are surrounded by inflammatory cells that are shooting like missiles, free radicals, at the thin plaque. The person lights up a cigarette. Innumerable hydrocarbons are absorbed. They're very pro-inflammatory. That could lead to a thin fibrous plaque rupturing. Many variables. It's not clear what does it, but it's probably a host of inflammatory substances in a vulnerable plaque.
Any other pressing questions?
No, I want to hear what Steve says.
Please.
Well, the funny thing is, we're all exposed to similar risk factors, but not all of us develop severe plaque. All of us have. There's probably been a dozen plaque ruptures in this room this morning so far, and nobody's had any heart attacks. So we all have plaque rupture. But why does the one? And then sometimes our plaque ruptures, and we get a clot that's so big that closes off the artery. There are 3 different factors. Inflammation is one of them, and clotting is one. But I think Dr. White said earlier, that's a Nobel Prize winning question. Why do plaques rupture?
Foster